fail this exam. And I quickly said to myself, get yourself together. And the exam went very smoothly. So don't be phased when you see syndromes or complex cases. Just gather yourself and go for it, and you'll be fine. So the foot and ankle, you've heard about the hip, you've heard about the knee. There's going to be a lot of repetition to what you've heard. But remember, the foot and ankle is many joints together. It's a complex area. So you have to have a system and go through it systematically, and you should be fine. So, like we've heard, it's all about look, feel, move. But in the foot and ankle, if you look carefully, most situations you'll come to a diagnosis or more or less have an idea what you're dealing with. So have a good look at the patient and have a good look at the feet or the ankle, depends on what you're examining. So that's your system. You've heard about look. When you look standing, look walking, look sitting. Then go on to palpate, move, and then you can do your special test as required. So when you approach your patient, it's different between clinic and exam. In clinic, the patients will walk into you. So as they walk into you, you look at them. In the exam, most patients will be seated. So as you get to them, you have to get them to stand. And you have to be polite and say, please, can I get you to stand? You may be told, sorry, patient cannot stand. Examine them sitting. But it's always good to get them to stand. And as they stand, you must be seen to be looking very carefully. Now, look from the front, look from the sides, look from the back, okay? Because certain things you may not see when you look from the front. You may not notice a severe valgus deformity when you look from the front. You may not notice the 2-minute toe signs when you look from the front. Looking from the back, you may not notice a severe hallux valgus deformity. So front, sides, back. And tell the patient gently, can you please stand around? And look, and you notice all the things you need to look out for. I just developed a mnemonic, the A, B, C, D, E, and these are some of the things that you must be looking for. Look at the alignment, the attitude. You can see the severe valgus here in this leg compared to that. Even both sides are the same. Look for body prominences. This is quite obvious there, but if you look from the back only, you may not see it, okay? Look for scars, and I tell you, lots of people miss scars, and scars will guide you a lot in your exam. And some of them are very subtle, okay? But be seen to be looking for them. And here you see the scar for hallux valgus surgery. It's not very obvious, but it's there, okay? And they do fade away well, so you may not always spot them. Look for deformity. Look at this forefoot. Multiple deformities, not just one. And please, when you comment on deformities, do it in a systematic fashion. So either you start from the big toe and work that way, or you start from the little toe and work that way to describe the deformities. Don't just go, I can see a hammer toe, I can see a claw toe, I can see a hallux valgus. Start there, and move in that fashion. So your examiner knows this guy knows what he's doing, or girl. Okay, and then look for erythema. You see here erythema. There is some swelling. And this patient has gout. You may not see gout in the exam, but yes, this patient has gout, even though they've had previous surgery with a scar. So you look standing, and while standing, if you notice certain features, abnormalities, and examples include pes planus or cavus foot, at this point, you can then focus your exam in the line of what you've noticed, okay? In this course, we are teaching you how to do it completely, but go along with what you see. So if you notice pes planus, just continue the exam in the line of pes planus, okay? Or cavus foot, continue in that line. You see people come to the exam and they're being asked, what do you see? And they go back to basics and go, keep going, keep going. What have you noticed? Stick there and just go through the exam, because you only have 5 minutes to get to the end point for what you noticed. So if you see pes planus, these are some of the things you must be thinking about, okay? Think about Baton's signs, especially in the young ones, even though adults may also have a flat foot with ligamentous laxity. Think of the 2-minute toes sign. In the normal person, you expect to see 1.5 toes. If you see more than that, then yes, it fits in with your pes planus. And usually, for many patients, you will notice about 3 or 3.5 or even more. You then go on to get your patient to tiptoe. Please, when you tiptoe the elderly, always find a surface you can get them to lean their hands against. Don't do it in the middle of an area, exposed area, because they may tumble. And if they tumble and miss a step or fall, you cause them more pain, you cause them more aggro, you upset the patient, okay? So find a surface they can lean their hands against, go double, and then ask if they can also do single. You find a lot of elderly patients who have tibialis posterior or middle-aged tibialis posterior insufficiency may not be able to do a single leg toe rise. And we'll demonstrate this in the afternoon section. Then also check for subtalar movement. Just a caution here, if you see children with flat feet or pes planus, please don't start talking about tib post insufficiency. Many, many candidates make this mistake, and it demonstrates your ignorance. So, guy, you don't know what you're dealing with, okay? So do not go that way. Think about tarsal collision, flexible flat foot. And if you're thinking tarsal collision in a young patient, you must be shown or show the examiner you know how to examine for subtalar joint movement, because that can give you the clue or the answer. So, in this case, look at this picture here. You can see when this patient tiptoes, the left side still remains in severe valgus, so it doesn't correct. So this is stiff compared to that side. That side corrects to a reasonable degree, though not fully. Okay, so moving on from pes planus, now go to pes cavus. These are two different things. For those who don't know, I'm sure you all know, pes cavus is a foot with a high arch, okay? And this is one place you must do your Coleman block test, okay? The foot is likened to a tripod. The first ray, the great toe, the first ray, the fifth metatarsal, the fifth ray, and the hind foot. And in these patients, the first ray is usually plantar flex. So they tend to compensate by tilting the hind foot into varus. And the reason for doing the Coleman block test is to see if the hind foot is flexible or not, okay? If it's flexible, the Coleman block test will correct. The hind foot will go into varus. So, go into valgus. So look at this case here. This is your Coleman block test demonstrating, and you must always offload the first metatarsal, okay? People make that mistake by keeping the whole forefoot on the block. So offload the first ray, and as you offload the first ray, you find in this case, it corrects to neutral, okay? So in this case, it is a flexible deformity, and that would dictate what you may wish to do surgically for this patient. Also, think neurological. Say to the examiner, I'd like to examine this patient neurologically. He may then say to you, sorry, we don't need to do that in this case. Everything is normal. But be seen to be thinking. And look at the patient's hands, because many of these patients may have Charcot-Marie tooth or some other neurological condition. And if you look at the hands, it just gives away the diagnosis. You look at all the severe muscle wasting, okay? So always be seen to be looking that way to show that you know what you're dealing with. So while standing, you can also assess range of movement very quickly. You can get them to tiptoe, go up on their toes, and go up on their heels. And this can also sometimes tell you if they have a stiff joint in addition to what you already have noticed, okay? It's because you may see an asymmetry between the two sides. So look while standing, look whilst walking, okay? Look at the rhythm, the cadence, attitude, symmetry, and stability. And you may notice that the patient may have an externally rotated limb as they walk, and this may be due to a stiff ankle or some other pathology. They may have a high stepping gait, which may be due to some nerve abnormalities, a problem with their back, foot drop. They've had surgery in the past, the nerves have been damaged, they presented to your clinic with a foot drop, and hence a high stepping gait. Or they may have a tibialis posterior dysfunction with a medial arch collapse, which may be so obvious as they walk, as opposed to either just sitting. Then you get them to sit down, because you must always be seen to be looking under the foot and between the toes. And if you look at the patient carefully in this case, you see the scar here, and you see these ulcers, okay? And once you start to see these, straight away you can be thinking this patient may have diabetes or some neurological condition that they cannot discern. The sensation is poor, okay? So you'll miss things if you don't look that way, okay? Also, whilst looking at the patient, look around. And you may have done this when you just entered the room. Look around the patient. The first thing, are there any orthoses, any braces, any special shoes, any walking sticks? Because when you comment on these, it gives you extra points. If you don't comment, he may then say, what about those things lying there? The examiner says, and then you feel like, oh, I'm so stupid, I didn't spot these. So look while sitting before you move on to the next part of your examination. palpate. Focus on the area of the pathology. So if it's forefoot, palpate the forefoot. If it's ankle, palpate the ankle. And please know your anatomy. Don't go palpating the medial malleolus and say this is the navicular. Or don't palpate the navicular and say this is medial malleolus. Don't palpate some tendons and say you palpate on the extensor aspect and you call that a flexor tendon. Okay? So know your anatomy and know what you're palpating. Once you palpate, so bony landmarks, tendons, you must also, at some point, palpate for neurological status. So pulses, okay, and know which pulse you're palpating, and also areas of sensation. So know which nerves you're feeling, which nerve supply, okay? Common perineal, deep perineal, superficial. So know which ones you're dealing with. Then go to move, okay? When you start to move, again, have a system. Either you go from proximal to distal, okay, so from the ankle joint distally towards the toes, or go from the toes towards your ankle joint. Again, depends on which joints you've been asked to focus on or what the pathology is. Again, we talked about this. Do you do active? Do you do passive? In most situations, we go straight for passive because the examiner wants to see that you can demonstrate how to examine, for example, the ankle joint or the subtalar joint. Active mostly if you suspect some neurological condition or if the patient has a very stiff joint. But you can also descend that if you do passive. And because of the multiple joints in the foot and ankle, you must be seen to be isolating or excluding other joints from your examination because certain movements involve a number of joints working together. So, how do we examine for range of movement? We'll show this more this afternoon, but these are just a few points about examination of joint movement. Ankle joint is one joint that is not easy to examine because you could be showing all the movement from other joints and not specifically the ankle joint. So one of the most important things to do is your patient must be comfortably seated with the foot flexed, the knee in a flexed attitude, okay? And as you do that, as you go ahead, you must keep the forefoot supinated to exclude movement from show pass joint and keep your hind foot in an inverted position to lock out the subtalar joint. And one way of doing this easily is to keep, you can see what I'm doing, one hand under the foot, inverted, supinated, and the other hand here. Look at the patient's face, and then you plantarflex and dorsiflex gently. Okay, and by doing this, you can be certain you are getting movement from the ankle joint and not other joints. So that is the ankle joint for you. Subtalar joint, another difficult joint to examine for many people. And again, here, what you want to do is to exclude movement from your ankle joint, but also from your show pass joint, even though some of the movement will come from your show pass joint. So you can see here, the examiner has his left hand on the neck or head of talus, and you must be seen to be stabilizing the talus, okay? Otherwise, your movement will be partly from the ankle joint. So here, you lock out the ankle joint by holding that your talus firmly, medially and laterally, and then you hold your foot, hind foot, and then you evert and invert, okay? And this is subtalar joint movement, okay? And lock, you keep the rest of your foot supported in your hand, in the palm of your other hand. We'll demonstrate this afternoon. Show pass joints, again, some of the movements from these joints, that is the talonavicular and calcaneocuboid as they work together, may link to the subtalar joint. So you can see here carefully, one hand stabilizes the hind foot, and the other hand stabilizes the mid-tarsal joint so that you can just test your show pass joint. And movements from this area will be pronation, supination, a degree of abduction and adduction. And the movements of abduction and adduction are very subtle, just about 5 degrees either way. So this is your show pass joint. Going on to the mid-tarsal joints, again, very limited movement here. You just move your hands along. So here, you can see the right hand is stabilizing the calcaneocuboid joint and the talonavicular joint roughly, and then you move your other hand just distally, okay, before the metatarsophalangeal joints, and then you test the movements there. First ray, again, some of the patients may have hallux valgus, some may have hallux rigidus, okay? So again here, one hand must be stabilizing the metatarsal, which you can see, it may not be very clear here, but one hand has to be on your first metatarsal, and the other hand must hold your great toe just proximal to the interphalangeal joint, and then you move that joint and watch the patient as you do so. And if you suspect hallux rigidus, then you may go on to do your grind test, but do it carefully and gently because the patient may be in a lot of pain when you do that. And that's a rotatory movement with compression on the joint. The lesser toes or lesser rays tend to move together. Okay, they move, so your second, your third, your fourth, your fifth move en masse. So if you're focusing on a particular toe, which you may be asked to do, then you must be seen to be locking out the others and keep just testing that joint. And one of the things we do with toes is that you must decide if the deformity you see, for example, a flexion deformity, is passively correctable or fixed. Because if it is fixed, then your treatment of choice or your surgical treatment may vary from if it's passively correctable. And we'll demonstrate that later on this afternoon. Muscle testing. Again, this is one place where people tend to fall down. Okay? So we're starting from the tibialis anterior, moving on to the peroneus longus. I chose these three because these are the most common. So here we're testing the tibialis anterior. And what you must do, your patient seated comfortably, get them to dorsiflex the ankle and invert. Okay? And you can see one hand is on the tendon to feel contraction of the tendon, and the other hand is to try and tell your patient to hold the foot there, and you push them laterally or evert the foot. And as you do this, you'll be testing your tibialis anterior. Okay? Your tibialis posterior, slightly opposite, so the patient plantar flexes. Okay? Again, inverted. You tell them to resist your action by you trying to evert them or push laterally, and you keep your other finger or other hand, finger of the other hand on the tibialis posterior tendon. So don't go anteriorly at the back of the medial malleolus. Okay? And this is a peroneus longus. With the peroneus longus, you have to plantar flex the foot and evert. So get the patient to plantar flex and evert, and you tell them to hold it there, and you try and push the foot away from that position. Again, you see I have one finger on the peroneus longus. With the peroneus brevis, you keep them in neutral, and you evert. Okay? So that's the difference between brevis and longus. Special test then, if you may be asked to test the Achilles tendon, okay? So this is, you're unlikely to see Achilles tendon rupture in the exam, but you may be asked to examine a patient for Achilles tendinosis. And this is a Thompson's test for Achilles tendon rupture. I'm sure you all know. I won't go into that. Ankle instability. Again, ankle instability is not very common, but occasionally you get asked. You either do the anterior draw or you do the varus stress test. The anterior draw testing your anterior talofibular ligament, and your varus stress testing your calcaneofibular ligament. Okay? And get your patient seated comfortably and relaxed. This test can be very difficult because if the patient is in pain, they'll resist you doing it, and it's usually best done with some form of anesthesia. Anterolateral impingement. Again, this test, you get your patient to plantar flex, have a finger of yours or your thumb apply pressure to the anterolateral aspect of the ankle joint. As you do so, watch the patient's face. They may have some pain, and then when you dorsiflex the ankle, the pain may increase with your finger kept in that position. So this is for anterolateral impingement. Sorry. So that's the end of the foot and ankle examination. It's all about having a system, as you've heard, and going through that system. But remember what I said. Once you spot your pathology, please go straight there and don't beat around the bush. Otherwise, the examiner will say, what next? What next? And you start to panic. Okay, thank you. Most foot ankle cases, you may be asked to examine the ankle joint for instability is rare. You examine the ankle joint, examine the forefoot, and you will see some deformities there. You may see hallux valgus, notice stiffness of the MTP joint, the big ray, that hallux rigidus, you may notice a flat foot. So it's unlikely you get those type of cases.
But then as part of the condition that they had, they may develop ankle stability. After collision.
If you feel, but usually no, tarsal collision they'll be stiff, so they won't develop. Yeah, the time will run out. You won't get to that point.
Very
Have you?
rarely you get.
Yeah, I've never seen anybody get to that point because 5 minutes is so short. Yeah, go ahead.
There's one thing that's starts to describe where you hold the lesser metatarsals
Yes.
in dorsal flexion, so you kind of make a plantigrade foot. Is that for testing range of movement? Or
Well, say that again. What was your question?
I can't remember which test you need to do this in, but you have to push against the lesser metatarsals to examine the first ray. Is that for instability or is it just for the range of movement?
No.
Probably multi-click is for
Modest click, you squeeze. I don't know what. Yeah, but when you're testing the lesser rays to see if you have, for example, a second toe deformity, flexion deformity. I don't know if that's what you're saying. And if you want to see whether it's flexible, sometimes when you push the foot up, is that what you're saying? When you push the foot, dorsiflex the foot, you relax the tendons or you stretch the tendons. So as you do that, the deformity may correct. Is that what you're saying? I think that's what you're trying to do.
Some people do Peronis longus like that.
Yeah.
That's when you work and if you put your hand on the outer side of the foot and then you feel the first ray because Peronis longus goes around insert into the first ray. That some people will examine the Peronis longus like that.
Okay, I'll pass you on to the spine section.
One of the benefits you have here that most people here who are tutoring you today are examiners.